One of your patients is anemic. What are you going to do about it? Well, take a history. The 4 symptoms you're looking for are shortness of breath, fatigue, palpitations and dizziness. Then look at the past medical history. Are they thalassaemic? Do they have liver disease or kidney disease? And do they have cardiac disease? Because if they do, that will change the threshold for transfusion. On examination, are they obviously hemodynamically unstable? If they are, do something about it quickly. Then you can look for the signs of anemia, for example conjunctival pallor, your pale skin creases, your angular stomatitis, your guthitis, and your chronic liver disease and kidney disease stigmata. For example, if they've got a great big arteriovenous fistula throbbing away on their arms, it's a good chance that the anemia is due to kidney disease. So what are the most common causes of anemia in a hospital setting? Well, in medical school, one of the first things you learn is that anemia can be caused by iron deficiency or B12 folate deficiency, but actually these are quite rare in a hospital setting. The most common cause of anemia is anemia of chronic disease. Then you've got acute blood loss, which as I said you need to do something about quickly, and then you've got post-operative blood loss and chemotherapy. Those are the most common causes of anemia in a hospital setting. So now you've got to do some investigations to work out what the cause actually is. Now don't just call a haematologist whenever you find anemia, because all they're going to do is ask you to do the exact same battery of tests which I'm going to go through with you now, and then ask you to bring them back. So it's going to save you time if you just do these tests first and then think about it. It's your job. First thing you're going to look at is the mean corpuscular volume, the MCV, and the normal range for that is 80 to 96, which you can remember easily by remembering 88 plus or minus 8. That allows you to divide the anemia into microcytic, the causes being iron deficiency, thalassemia and sideroblastic anemia, normocytic, the causes being anemia of chronic disease and acute blood loss, and macrocytic, the causes being B12 deficiency, folate deficiency, chronic liver disease, alcohol, myelodysplastic syndromes and hypothyroidism, and yes, it is worth memorising those. Once you've done that, the next thing to do is a blood film, because that can reveal all sorts of abnormalities in the red blood cell shape, and I'm not going to go through all of them now, but just as some examples, you can find some pencil cells, which could reveal iron deficiency. You can find schistocytes, signs of hemolysis, spherocytes, also signs of either hemolysis or hereditary spherocytosis, or you might find some weird leukemia or myeloma cells. So, based on what I've just said, you should do the haematinics: B12, folate, iron, transferrin saturation and ferritin. And you should also look for the other things I've mentioned, like your liver function tests and your thyroid function tests. Of course, there are lots of things which don't fit into this classification of MCV. For example, hemolysis, which can give you a normocytic or a microcytic anemia. So, because of that, you need lots of other tests as well as your MCV and your haematinics. The next thing you want to do is a hemolysis screen, which consists of the following things: bilirubin, which will increase, haptoglobin, which will decrease, LDH, which will increase, reticulocyte count, which will increase, and the DAT test, direct antiglobulin test, also known as Coombs test, which if there is a hemolysis will tell you whether it's immune mediated. That's your full hemolysis screen. Because the anemia might be immune mediated, you need to do an autoimmune screen, which is of course ANA, ANCA, ENA and immunoglobulins. The next thing, and probably one of the most important things to do, is a myeloma screen, especially in an elderly person, because you never know, and if you miss it you're in trouble. The last thing you can consider doing in anemia is an EPO, because if there's chronic kidney disease then that will prove that that's the cause. The last thing to say is, if you don't find the cause of anemia in an adult after doing all of those things, then you have to do a top and tail. In other words, an OGD and a colonoscopy to look for any occult causes of anemia, for example malignancy or gastric ulcers. If you don't do that, you're going to land yourself in a lot of trouble. Now, as I say, the most common causes of anemia that I see are the anemias of chronic disease, kidney and liver, and usually it's multifactorial. You usually find more than one cause. So for example, in liver disease, the most common cause is iron deficiency, because the liver synthesises hepcidin, which is involved in iron metabolism. But it can also be caused by splenic sequestration in the case of portal hypertension. In kidney disease, of course, the cause of anemia is a low erythropoietin, because the kidneys are supposed to synthesise that, which stimulates red blood cell production in the bone marrow. That's why we measure EPO, as I said before. So it's important to think laterally and to consider lots of different causes, because it is usually multifactorial. There are 1,000,001 causes of anaemia, and frankly, I don't have time to go through them all now, and I haven't gone through them all now. I've not even mentioned sickle cell anemia, for example. I've not even mentioned the various infectious diseases that can cause iron deficiency anemia. You know, there are so many things, and you've got to think about all of them, but the tests that I've talked about are your basic set of tests that you need to do, and that will give you a good idea and rule out the common things, because remember, common things are common. This is intended as more of a practical guide, but I'll leave some extra reading material in the video description below so that you can read more about the different causes of anemia and how to investigate them.